for all your achievements that you've done from the Royal College of Radiologists. So yes, I'm going to speak to you today about the diagnosis of skeletal dysplasias, and you'll see that I've called it as easy as ABC. And as we go through, you will probably understand why I've given it this title. So, okay. So in the latest publication, which was 2023, of the International Skeletal Dysplasia Group, the nosology that comes from that group every 5 years or so, the 2023 revision actually identified 771 different skeletal dysplasias associated with 552 genes. So although we have an hour, which is generally longer than a lot of these talks, you will understand there's no way we can go through 771 conditions. So what this talk is about giving you an approach that will help you narrow down at least to a group or a set of groups of conditions that you think the patient in front of you, the imaging of the patient in front of you might be representative of. So generally speaking, it's all about pattern recognition. And if you can identify which aspect of the child, which aspect of the radiograph is abnormal, you at least have a beginning. Is the child overall small but proportionate? Is it a short trunk, or is it a short-limbed dwarfism that you're dealing with? And really, it's excellent if you know which pattern. It narrows the diagnosis for you. And just the first few slides are for you to write down your answers to some questions. I don't think they're too difficult, but they vary in their difficulty because I don't know who you are in the audience. And just to ask yourselves if you know the meaning of mesomelic, rhizomelic, micromelic, and acromelic. Try and write it down, because when we say things to ourselves in our heads, we generally overestimate our knowledge and how correct we are. Okay, then the second slide, we move on to slightly more challenging question. You can see that there are 4 radiographs here, 4 chest radiographs, A, B, C, and D. And then down the right-hand side of the slide are 7 conditions, and each of those chest radiographs belongs to one of those conditions. So there are 3 conditions not represented. So whilst I've been talking, and I'll give you a few more, a minute or two, just to say whether you think A is, which of those 7 conditions you think is A, which of those 7 conditions you think is B, and so on and so forth. And again, as I say, do try and write it down. Nobody else will know the answer but you, or whether you got it right or wrong. It's just for your own learning. It always makes us think harder and do better if we make an effort. Okay, and then now we move on to pelvic radiographs. Again, the same 7 conditions that we had on the previous slide, but pelvic radiographs. And they're not necessarily the same condition each time. So the pelvic radiographs may not correspond to the chest radiographs. So A, whatever you put for A in the chest doesn't have to be the same answer for A in the pelvis, if that makes sense. Okay, so we'll find out the answers later on. I hope. I'm thinking that they've got them there. So we talked about skeletal proportions, and the important thing, I know that a lot of us, the clinicians, don't necessarily tell us on the card, but we can always make the request. And if they do put it on the card, we need to understand what it means. So if you stand with your hands aside at 90 degrees, as in this image, then from fingertip to fingertip, your span is essentially the same, more or less the same distance as your height from the top of your head to the ground. And that's you see that's the normal proportions that we should have. And similarly then, from your crown to your pubis will be approximately the same distance as from your pubis to the floor. The fingertips will, in the standing position and your hands by your side, approximate towards the symphysis pubis. And if we take this line and assume that is the height of an average adult individual, or an average 10-year-old child, or an average 5-year-old child, whatever the age you want to give to that person, Then we take this individual. You can see that they're slightly shorter. Their fingertips come to the iliac wings, so that means they have a short-limbed dwarfism. In this instance, their span will be less than their height. And that may be something that the clinicians will say, spine less than height. What they're essentially telling you is that they have short limbs. This individual is also short, but they are short, as you can see, because their spine is short. Their limbs are the normal length. In this instance, their fingertips approximate towards the knees. Their span is greater than their height. And then this person is altogether shorter than the other two. They have short spine, short limbs, but they are actually proportionate. Their fingertips approximate to the symphysis pubis. Their span is approximately the same as their height. From their head to the symphysis pubis is approximately the same as from the symphysis to the floor. Now, most skeletal dysplasias are either the short limb or the short spine. They are usually disproportionate. They're usually symmetrically disproportionate, but there is a list of some conditions that are asymmetric, and those will often be related to mosaicism. And we'll come to a list of certain conditions as we go through the talk. So in addition, there are other features that will be important on the request card or that you can speak to the pediatricians about, one of them being consanguinity, just to help to gear your mind towards whether you're dealing with an autosomal recessive condition or are you dealing with a sporadic autosomal dominant condition. It can help. An affected sibling or parent can also be helpful. If all affected individuals are male, you can say to yourself, well, this is likely to be an X-linked condition. And that will guide you in when you're trying to make the diagnosis. Is it lethal? Has there been or is there respiratory compromise? For example, all of the short rib syndromes with or without polydactyly. But if there is polydactyly, it's usually post-axial. If there's polydactyly, is there syndactyly? Polysyndactyly will make you think of Ellis van Creveld. Polydactyly alone is more likely Jearns. Jearn has polydactyly in 10% of cases. Ellis van Creveld has polysyndactyly in 90% of cases. These are approximate. Corneal clouding is one that is not common. So if they say on the card that there is corneal clouding, you have a nice clue towards, could this be a storage disorder? And when you have in your mind the condition that you're thinking of, when you look at the radiographs, sometimes if the findings are subtle, they're actually easier for you to detect because you're looking for that particular feature. So there are conditions, storage disorders, where the features may be quite mild. But if you know you're looking for a storage disorder, it can be helpful. So the moment you're considering that a child has a skeletal dysplasia, you want to do imaging. It's usually radiographs to make the initial diagnosis. Of course, we use cross-sectional imaging modalities to look at the brain, for example, to look at the kidneys, for example. But generally speaking, in making the initial diagnosis, it's on radiographs. And this talk today is really just on the radiographs. It's too broad a topic to go into some of the other cross-sectional features. So routinely, you want to do an apian lateral skull. You want to do the thoracolumbar spine lateral projection. You want to do the chest. On the AP chest, make sure you can see the full shoulder joints. The reason being, you want to make sure you can see the lateral ends of the clavicles, both sides. On the pelvis, that includes the AP lumbar spine. Make sure it includes the symphysis pubis. And you can see that I've given you examples that are not acceptable. You need to be able to see the symphysis pubis, because if they've got widening of the symphysis pubis, you will not know, and you may miss a diagnosis. Then the AP chest shows you the AP thoracic spine. The AP pelvis shows you the AP lumbar spine. You do not need to do a separate AP spine. One upper limb, one lower limb, and left hand. It doesn't matter which upper limb, it doesn't matter which lower limb, and frankly, it doesn't really matter if it's the left hand or the right hand, because to have advanced or delayed bone age, you need to be outside plus or minus 2 standard deviations. And in most individuals, the left and right hands will be more or less similar. There won't be 2 standard deviations out. Now then, there are some conditions where you may want to do additional views. So you notice that in the routine dysplasia protocol here, we talked about the thoracolumbar spine lateral, not the cervical spine. But you may want to do the cervical spine, and this table, in alphabetical order, lists some conditions that are associated with C1, C2 instability. And when you are considering those conditions, that may be the time to do a dedicated cervical spine view. Avoid the situation where you're trying to comment on the cervical spine on a lateral skull radiograph. Very often it will be oblique, very often it will not be central, and you may miss or overdiagnose abnormalities of the peg. If you're worried about an abnormality of the peg, do a dedicated C-spine view. Now, if the condition is asymmetrical, often, as I said, will be a mosaic condition, something like Ollier's disease, some of the gigantism syndromes, even sometimes neurofibromatosis, these sorts of things. Then you may want to do the imaging of both upper and both lower limbs. You're trying to find out, is one side overgrowing or is one side undergrowing? If you're dealing with a fetus or an infant, you may do the whole babygram, an apian lateral of the whole fetus or the whole infant. But even when you're doing those, I would advise that you do the hands and feet separately. You may miss soft tissue or even bony polydactyly. You may miss clues in the hands and feet that will help you to make a diagnosis. And sometimes then you want to image family members, particularly if they are younger than the proband, because a lot of these dysplasias, if you image by the time the growth plates have fused, often all you see may be signs of premature osteoarthritis or shortening, but you might miss the clues to the diagnosis. If you already know a diagnosis in a family member, you may not, if they have had imaging in the past, you may ask to see that imaging rather than re-imaging the same family member. And of course, all of this is talking in the context of a child or an individual that hasn't had any imaging at all. If the child came in last week with a cough and had a chest radiograph for their cough, obviously you're not going to repeat the chest radiograph because you've already got one to look at. Now, there are occasions where you have all of this in front of you and you're pulling your hair out. You have no clue what the condition is. And you say, and we have this instinct of, all right, I'll image again. Fair enough. Sometimes you may want to image again, but this follow-up imaging should be limited. There is no point imaging sites that were previously normal unless there's a clinical indication. So restrict yourself to areas that were previously abnormal. Do not repeat it before a year. If the whole purpose of repeating the radiographs to try and make a diagnosis, the evolution will not be fast enough. There is no point repeating it before a year, and there's no point repeating it next year and then the year after. We have to at some point decide we do not know what this condition is. Let's manage symptomatically and let's publish or let's ask friends. Let's sit back and maybe at some point we'll be able to make a diagnosis, but don't keep imaging the child in the hope that something will you'll make a diagnosis. So then you've got your imaging in front of you. You now want to look at it and try and reach a diagnosis. And this is where the ABC comes into it. Anatomical localization, bones, characteristic findings and complications. And is the child dead or alive? Are you dealing with a lethal or a non-lethal condition? The D is also for the dysplasia protocol, which we've just been talking through. So in terms of anatomical localization, one of the questions I had asked in the earlier slides was the meaning of rhizomelic, mesomelic, and acromelic. And you can see here that rhizomelic, rhizo means the root, so humerus and femur, the proximal segments. And the commonest, so we talked about 771 conditions in the nosology. Here are the typical commonest conditions affecting the segments that are here. So rhizomelic, often achondroplasia, chondrodysplasia punctata, rhizomelic type, and Larsen syndrome. Mesomelic is the middle segment, Ellis van Creveld, Jearns, asphyxiating thoracic dystrophy, and dyschondrosteosis, Léry-Weill syndrome. Acromelic, if you remember acromegaly, hands and feet. distal segments. Pseudo-hyperparathyroidism. Anytime you say pseudo-hyperparathyroidism, in your head, you should also say pseudo-hyperparathyroidism. Acromesomelic dysplasia and acrodysostosis. You can see that those two have the condition in their names, acro. So you know that acro and mesomelic is affecting the hands and the feet and the mesomelic segments. The black is micromelic, where all segments are affected. But as I say, micromelic conditions are very often not skeletal dysplasias. So here is a rhizomelic chondrodysplasia punctata. You know that Conrad Huneman is also a form of chondrodysplasia punctata, but it's not the rhizomelic form. Here you can see the humerus on the most extreme image, far shorter than the radius and ulna, with the punctate calcification around the proximal humeral epiphysis and the lateral end around the glenoid. And then the same child, short femur with punctate calcification at the proximal and distal ends of the femur. And if you see the lateral spine, here there is radiolucency in the mid segments of the lateral spine, and we call those sagittal clefts. They're running through in that plane. And then we have the coronal clefts on the lateral running through in the coronal plane, and the sagittal clefts on the AP, which are usually what we call butterfly hemivertebrae. So sagittal clefts and coronal clefts are actually quite common in chondrodysplasia punctata. And remember that the punctate calcifications coalesce and may no longer be visible by the time the child is 3 or 4 years old. And all you may have left might be a scoliosis or abnormal spinal segmentation because of the abnormal fusions of the clefts of the vertebral bodies. Bear in mind that in male infants, coronal clefts, as here, of the lumbar spine may be a normal variant. The other condition that is typical is achondroplasia. Typical rhizomelic is achondroplasia. And in an infant, a newborn, the clinical features may actually be quite subtle, and it might be difficult to make a diagnosis of achondroplasia, and it will be us, the radiologists, that will be called upon to make that diagnosis. And if you remember nothing else, remember the ice cream scoop appearance of the proximal femur in a neonate with achondroplasia. Here we see the umbilical cord clamp. Here we see the ice cream scoop appearance of the proximal femur. It's because of the sloping metaphyses on both sides. There are other features. They have a horizontal acetabulum and it's trident. They have a lateral spur, an intermediate spur, and a medial spur, giving you a trident acetabulum. They have a very short sacrosciatic notch. So if you remember those features, it is helpful in making the diagnosis of achondroplasia. The short rib polydactyly syndromes are the other conditions that will give you a trident acetabulum, but they will not have this ice cream scoop. To be fair, I don't know another condition that gives you this appearance. I would go as far as saying that it's pathognomonic of achondroplasia. And then there are other features of achondroplasia that we should be looking for. The short ribs with a small thorax. It can be quite subtle in terms of rib shortening. I tend to see how much of the scapula can I see outside of the ribs, and where do the anterior rib ends meet? Where do the anterior rib ends reach? Are they as far as the mid-clavicle on the AP chest? And if not, then I'd be thinking of short ribs. Here again, we see the trident acetabulum. This is a 3-month-old. We see a very short sacrosciatic notch, and we see the ice cream scoop appearance with the horizontal trident acetabulum. Here, bullet-shaped vertebral bodies. Many of us will not have seen bullets, but it's this posterior scalloping, this anterior concavity, and then the trident hand, because the fingers do not oppose. Now, see the lateral, I didn't know why they did, this is not a good lateral spine when you can see almost to the knees, but it is helpful where we can see the sloping metaphyses on the lateral view which is what gives us this ice cream scoop appearance. So those are the features that you would see in an infant with achondroplasia. As the child gets older, you lose the trident appearance. The sacrosciatic notch remains small. You lose the ice cream scoop appearance. In fact, the proximal femoral epiphyses become relatively enlarged. The femoral neck becomes short. Because they get an increasingly horizontal sacrum with the posterior tilt, you might find L5 situated very low between the iliac bones. So the features that you see are age dependent. Of course, by the time the child is 5 or 6 years old, maybe even younger, you don't need the radiographs to make a diagnosis of achondroplasia because the clinical presentation will be very clear. Then this progressive narrowing of the interpedicular distances from L1 to L5 that we see in achondroplasia is not something you will see in the infant spine. So don't be dissuaded from making a diagnosis of this in an infant because the interpedicular distance is not narrowing. In a normal individual, it gets wider from L1 to L5. In achondroplasia, it gets narrower. In hypochondroplasia, it may just stay the same. It won't widen and it won't necessarily become narrower. It's due to short pedicles, and then they get the spinal stenosis. And because of the short pedicles and the spinal stenosis, they may get the posterior scalloping. The other thing to look for is the large vault with prominent parietal and frontal bones. They have a short base. They may get spinal cord compression at the level of the foramen magnum, and nowadays we would advocate screening children, a baseline of MRI of the foramen magnum around 3 months or as early as you can, and maybe again at 1 year. Remember that they get ventriculomegaly. When I was training, most children, most infants with achondroplasia had the VP shunts. People thought it was hydrocephalus. Hydrocephalus in this situation is actually rare, and the correct term is ventriculomegaly. It's not under pressure. And here is an example with the ventriculomegaly, but in particular, you can see that they've got foramen magnum stenosis, and they have a low signal on T1 within the cord at the level of the foramen magnum, which would be a grade 4 in the achondroplasia foramen magnum stenosis score. This would require surgery because this infant would be at risk of sudden death. And here are the changes in the spine. In the neonate moving up to 14 years of age, the posterior scalloping, bullet-shaped vertebral bodies. Then they get short pedicles, an increasing thoracolumbar kyphosis, and an increasingly horizontal sacrum. So that was achondroplasia as the condition of the best example of a rhizomelic skeletal dysplasia. If we move on to mesomelic dysplasias, remember Jeune. Most people remember it because of the short ribs and the respiratory difficulty, and that is probably in terms of the patient management and presentation, that's correct. That's how it should be. They have the short ribs. Mesomelic shortening means short tibia and fibula and relatively short radius and ulna. They may get this cone-shaped epiphyses, particularly in the hands, which we often forget to look for. And as I say, 10% of Jeunes have polydactyly. I don't know that I very rarely have seen syndactyly in Jeune, compared to Ellis van Creveld, where they get polysyndactyly 90% of the time. And then, of course, with EVC, they have the cardiac abnormality. The other conditions, acromelic, think about pseudo-hypoparathyroidism, in particular the short metacarpals 3 to 5, but it doesn't have to always be 3 to 5. It can be more uniform. It can be 1 and 3. It can be 4 and 3. But usually there will be some shortening of some of the metacarpals. So that was in terms of the overall segments. Unfortunately, the dysplasias don't just stop at that level. we then sometimes have to go into the anatomical localization of a specific bone. And here we see on this cartoon, if epiphyseal disorders will tend to present with joint disease, diaphyseal disorders with deformity, and metaphyseal disorders with shortening. It's just a way of remembering it, depending on how the pediatrician tells you the child is presenting, or even the adult. So again, commonest examples, not by any means exhaustive. Epiphysis, remember the multiple epiphyseal dysplasia group of conditions. So you may be thinking, so MED is definitely the commonest one, but you may also be thinking of conditions such as spondyloepiphyseal dysplasia congenita, so that those that affect the spine as well. Chondrodysplasia punctata, we showed examples with punctate calcification around the epiphyses, and then the mucopolysaccharidosis. To be fair, I've put it here, but it's really morquia that affects the epiphyses, and we'll show some examples just now. Metaphyses, in particular, think of metaphyseal chondrodysplasias, and in particular, think of Schmidt, because the differential there is rickets, healing rickets, especially. And then diaphyseal conditions are probably the least common: Engelmann disease, craniodiaphyseal dysplasia. Here is an example of multiple epiphyseal dysplasia, flattening of the capital femoral epiphyses, irregularity, particularly on the patient's left-hand side, and some dysplasia of the acetabula. So you have to ask yourself, is it a primary acetabular problem, or is it that the acetabula have not formed properly because the spherical femoral head has not been present? You need a spherical femoral head to make a nice concavity of the acetabulum. So you have to sometimes ask yourself which came first. The difference between MED and Perthes disease is that MED is usually synchronous, symmetrical, happening at the same time. Perthes is usually metachronous, one side first, followed by the other. If it is at the same time, it's rare. It's about 10 to 15%. So here we have a case of Perthes. It's bilateral, but you see that the right-hand side of the patient is the more sclerotic compared to the left-hand side. There's the coxa magna. The acetabula are relatively better formed than we saw in MED. And here is morquia with symmetrical flattening, irregularity of the capital femoral epiphyses. But what else that you see here is coxa valga, which is a feature of the storage disorders. You see the flared iliac wings, and you see shallow acetabula. So these are the features that you might look for. The other thing is they sometimes get these relatively small lesser trochanters. So here we're going back to the morquia at 5 years of age with coxa valga, with flared iliac wings, with shallow acetabula. And then this is the 10-year-old. So what happens is that they actually start off in morquia with normal capital femoral epiphyses, and then it gets resorbed. Enzyme replacement therapy these days prevents these skeletal abnormalities, but it doesn't reverse them. So, but if you're giving it by the time the capital femoral epiphyses have collapsed, they're going to remain collapsed. But if you give the enzyme replacement in time, you can stop the collapse from happening. So really important to make a diagnosis early. So the other clues to the storage disorders on the radiographs, the constellation of these features is called dysostosis multiplex. The different storage disorders will show the different features to different degrees, and it's not present in all of them. But if you know what to look for, and you look for it, and it's subtle and it's mild, but it's there, you can say, well, actually, do the gags, actually check the urine, actually, have you considered a storage disorder? Your job may not necessarily be to say, this is definitely Hurler's, this is definitely Sanfilippo. Your job will be to say, consider a storage disorder. Look for these, the platyspondyly, mild platyspondyly, with anterior hooks of the vertebral bodies, with posterior scalloping, and then sometimes with hypoplasia of a lower thoracic or upper lumbar vertebral body. as in this example, which may give you give the child a kyphosis at that level of a hypoplastic vertebral body. People will say, are the anterior tongues at the inferior, at the middle, or at the superior border of the vertebral body? It doesn't matter. It's not been found to correlate. Don't worry about where they are. Just look for them, and if they're there, ask yourself. The other you may also see this in neurodegenerative conditions with the kyphosis, but you wouldn't see the other skeletal features. Look for broad clavicles. Look for broad ribs, especially if at the back they're relatively narrow and then they get broad. Consider a storage disorder. Look at the width of this clavicle, and you're just seeing the clavicle here, very broad. Look for macrocephaly with a ground glass appearance of the skull and an elongated, often called a J-shaped sella turcica. And look for the reduction in the carpal angle, which we have here. Look for the proximal pointing of the bases of the second to the fifth metacarpals, and all the bones may be relatively short and broad. So those are the features of dysostosis multiplex. Some will have atlantoaxial dysplasia, and so there'll be a risk of instability. They'll have a dysplasia of the odontoid peg, I beg your pardon, and then be at risk of atlantoaxial instability. Some will have normal intelligence, some will have reduced intelligence, some will have corneal clouding, and some will not. Really, I would advise you to just concentrate on making the diagnosis of saying these are features of a storage disorder, and then let the pediatricians do the tests to worry about the specifics, particularly at this level. Now, if you want to become a specialist in dysplasias, then of course you might start saying that, you know, the typical dysostosis multiplex belongs to hurlers. Hunters don't get the cataract. The odontoid hyperplasia will be with morquia, but you don't have to know all of those really at the beginning level. Then moving on to the metaphyseal, metaphyseal chondrodysplasia type Schmidt is probably the sort of the one I would like you to remember and to think about, because it might be confused with rickets. However, rickets affects the rapidly growing sites the most. So the knees and the wrists are worst affected in nutritional rickets. In Schmidt, the hips are the worst affected, as we can see on this radiograph. In rickets, where you have the active rickets, you'll have reduced bone density on the radiographs. At no point in time in Schmidt will you see reduction in bone density, unless the child happens, most unfortunately, to have two conditions at the same time. And then, of course, you have the normal biochemistry in Schmidt compared to rickets, but beware that in healing rickets, if the child presents late, the biochemistry may be normal. Look for these relatively rounded and large capital femoral epiphyses, the widened growth plate, the coxa vera, so varus is reduction in the femoral neck shaft angle, and some fragmentation. When you have a wide growth plate with normal bone density, that's where you want to be thinking about, is this either healing rickets or is this Schmidt? And if the hips look worse or equal to the knees and the wrist is looking relatively normal, it's unlikely to be nutritional rickets. So then think about Schmidt. So here's an example of active nutritional rickets with the cupping and the wide growth plates. There is mild reduction in radiographic density, but this is rickets in the healing phase. And here is the AP of the lower limb. So the same cupping. What you notice, though, is that there's the trabecular markings are more prominent, almost looking like an osteomalacic appearance, but just because of the healing rickets. The other thing to think about is this condition, which is X-linked hypophosphatemic rickets, and this has this curious sign, and it's actually quite common, especially if you're looking for it, that the features of rickets in the knees affect the medial aspects of the distal femur and proximal tibia far more so than the lateral. And when you see that, this asymmetric widening and cupping and irregularity of the growth plate, particularly around the knee, then raise the possibility of X-linked hypophosphatemic rickets. And remember that hypophosphatemic rickets is not always X-linked, so it can be autosomal dominant. And that also has this particular appearance on radiographs. So do think about, could this be hypophosphatemic rickets when you see the medial aspects affected in this manner. Diaphyseal conditions, Camerati Engelmann, this man here, the clinical picture and the radiograph are the same individual. I've never seen it as florid. This came from Christine Hall, who taught me and who gave me this radiograph. These are not obviously the forearms of the same patient. This is one that was referred to me, and it's just to show you that it can actually be quite subtle sclerosis and widening, some abnormal modeling of the bones. It can be painful. So that is the anatomical localization. If only that was where it was enough to make a diagnosis. No, sometimes you then have to go and look closer at the bones. And when you're looking at the bones, think of the 5 S's: the surrounding soft tissues, the shape of the bone, the size of the bone, the structure of the bone, and the sum of the bones. So the skeletal dysplasias, we can spend the next 5 hours going through shape and abnormal shape, but we're not going to. Here is Pfeiffer syndrome, cloverleaf skull, premature fusion of the squamous temporal. You also get a cloverleaf of squamous temporal sutures. You may also get a cloverleaf skull in thanatophoric dysplasia type 2 for the same reason, premature fusion of the squamous temporal sutures. Does it matter whether it's type 2 or type 1? No, really, they're the same FGFR3 mutation. It's thanatophoric, it's lethal, but it's just that it's been subclassified in that manner. Pfeiffer syndrome, you'd of course look at the hands and feet. Structure, here's an example of increased density in osteopetrosis. You have to be aware of how this increased density might manifest morphologically. Usually what happens is that the normal bone is laid, but the osteoclasts don't work, and so the bone gets denser and denser. And when you treat a child with bisphosphonates, you're in fact giving them an iatrogenic osteopetrosis because the bisphosphonates inhibit osteoclast activity. Rugger jersey spine in the autosomal dominant types of osteopetrosis, the juvenile type, which is less severe, may not actually affect life at all. You do a chest X-ray for a cough and you identify this Rugger jersey alternate increased densities, the end plates, sclerotic end plates in osteopetrosis. Reduced densities, probably what we're more familiar with in osteogenesis imperfecta. When the child is born, they may have broad ribs, as in this example, because of multiple healing fractures that coalesce and give you broad ribs, or you may have slender ribs with beading, slender ribs with focal areas of increased callus that's called beading. I've put hypophosphatasia next to OI because any time you're thinking of osteogenesis imperfecta, automatically ask yourself, can this be hypophosphatasia? The reason is with Strensiq, with aspartase alpha, we can treat and we can save lives. Yes, it's expensive, but these children can now survive with enzyme replacement therapy. The features to look for are the abnormal ossification, and in particular, the strands of metaphyseal radiolucency that you might pick up on the chest radiograph at the proximal humerus. And here is the child OI with the iatrogenic osteopetrosis. Every time you give them the bisphosphonate, the osteoclasts are inhibited, and so you get a dense line, and that's why you get the zebra lines. And this is a bit of beading here, another fracture here that gives you the beaded appearance. And then the sum of the bones is, of course, polydactyly. Preaxial is the thumb side or the big toe, far less common than postaxial, which is little finger, little toe. Indeed, in some ethnic groups, postaxial polydactyly is quite common and occurs as an isolated finding. And then mesoaxial is central. This particular foot that I'm showing you has preaxial, so big toe, postaxial, so little toe, and mesoaxial, which is in the middle, polydactyly. The commonest is postaxial. We already looked at Ellis van Creveld and Jones. Then C is characteristic features. You know, you see all of these features here. You can read them. Exostoses, thinking of multiple cartilaginous exostoses. TRP2 is trichorhinophalangeal syndrome type 2, and they get the exostoses as well. Enchondromata with Olliers, with Maffucci syndrome, pseudarthroses, particularly neurofibromatosis and clinocranial dysplasia. We know that Larson's is associated with dislocations, and so on and so forth. If you see something that's relatively characteristic, you have to know that it's characteristic. But these are the things, if you're having to do a search, these are also the best things to search for, because the number of conditions with dislocations, for example, will be far fewer than the number of conditions that may have advanced bone age or something else. And then, of course, we've talked about polydactyly, the short ribs, the club feet. And here, I was saying, when you want to image both sides, it's usually these conditions that have mosaicism. And so something like Olliers or miliariostosis, fibrous dysplasia, Proteus, etc. These are the conditions where you may want to be imaging both the left side and the right side, but not routinely, because most skeletal dysplasias are symmetrical. So dripping candle wax is miliariostosis. And again, this is the best example I've ever seen, and I never really saw it. Christine Hall gave me the example. Nice, you can see why they call it dripping candle wax. The sorts of cases I've seen are more like this. You see on the left-hand side, so asymmetrical, and you see asymmetrical in terms of side, but also relatively asymmetrical in how severely the bones are affected. It's said to follow dermatomes. And here was one that was sent to me, the metatarsal. That was the radiograph. They were quite anxious about it locally. They were that anxious that they did an MRI, but the MRI doesn't really show you anything different to the fact that this is cortical bone, it's sclerosis, and it's miliariostosis. It's nothing to worry about per se. Hereditary multiple exostoses around the joints, pointing away from the joints, and nail patella syndrome, the characteristic being the iliac horns, which we can see here. But you'd also look for the radial head dislocation that they can get. And is it an important diagnosis to make? Yes, because it's associated with renal failure. And so you want to monitor their renal function and be able to treat them before they need renal transplant. Iliac horns. And of course, the hyperplastic patellae are the other feature that goes with nail patella syndrome, which is the name patella. And then, of course, a characteristic feature may be characteristic because it isn't there. Remembering the absence of the clavicles in cleidocranial dysplasia. Wide anterior fontanelle, multiple wormian bones, the chef appearance of the caprofemoral epiphyses with the coxa valga and the narrow iliac wings, and the broad ischiopubic symphysis pubis, I beg your pardon, the wide symphysis pubis, so cleidocranial dysplasia. And then the C complications, fractures are the commonest that we're looking at here in osteogenesis imperfecta. We've talked about subluxation, particularly C1, C2. We had the table in alphabetical order of the commonest conditions to give you C1, C2 atlantoaxial subluxation. We talked about doing dedicated lateral C-spine when you're worried about the C-spine. Don't look at the lateral skull. Progressive scoliosis, leg length discrepancies, malignancy. Remember the complications of therapy. Is that surgical screw loose? Is there infection around the tip of the screw? Many of these complications are the things that are important to the patient and their family, more so sometimes than giving a name to a rare disorder. Look for the complications, treat the complications, give them quality of life. And this is just to remind ourselves of what to look for in atlantoaxial instability. This is a 3-year-old girl with spondyloepiphyseal dysplasia congenita. Here we see the anterior arc of C1. Here we see a hypoplastic peg that should really be approximating the top margin of the of C1. Here we see the body of C2 and the posterior process, inflection. And then in extension, you can see how the hypoplastic peg has moved anteriorly to lie beneath the anterior arc of C1. Finally, we want to know if if the condition is a lethal condition, the D for dead. And this is just a small table to show you some examples. We talked about the nosology, which divides into the different groups and the number of conditions under those groups. So we've taken here the FGFR3 group, the type 2 collagenopathy group, the sulfation disorders, the short rib polydactyly conditions. Polydactyly may or may not be present, and then the bent bones. And in this column here, the lethal condition, and in this column, the surviving equivalent. And here is the fetus with thanatophoric dysplasia, with the bow telephone receiver femora that are short. If I blew this up, you'd see the horizontal trident acetabulum, you see the micromelia, you see the very short ribs, and this is type 2 with the clover leaf skull. This is achondrogenesis, again very short. This is type 2 achondrogenesis with the short and almost rectangular femora, short tibia and fibula, short ribs. Achondrogenesis, you have type 1A, type 1B, and type 2, but it's the type 2 achondrogenesis that belongs to the type 2 collagenopathies. The reason that they all have a similar names that before radiographs were done, on the clinical presentation, they were giving them these names. There are features that would tell you whether it's achondrogenesis type 1A or type 1B or type 2. Here we have the sulfation disorders, which would be a type 1B and goes into dystrophic dysplasia. And what you would get in type 1B is widening of the interpedicular distances in the lumbar spine. And that gives you the cobra head appearance. And that's what you should be looking for in type 1B. Type 1A is very, very severe, and they get extreme shortening, more so than we're seeing here. Then this condition here, this is a short rib polydactyly. This is type Majewski, type 2. Why? Because you see these short oval tibiae. And if you can count them, 1, 2, 3, 4, 5, 6, there is polydactyly. And then finally here is campomelic dysplasia. Camp means bent, and you see the bowing of the femur, junction of proximal 1/3 and distal 2/3, which is the opposite of the tibia, which is the junction of the proximal 2/3 and distal 1/3. More than that, because sometimes this bowing can be very subtle, you may just see a little tiny kink. Look for the absence of the scapular blades. All you may sometimes see is the spine of the scapula, as in this example, and very hypoplastic or very small scapular wings. There are other features, but if you don't see a scapular wing and you see very subtle bowing in the femur and tibia, campomelic dysplasia, you can then start looking for the other features. So in summary, we have gone through a systematic approach to looking at radiographs where we're considering a skeletal dysplasia. We talked about the dysplasia protocol at the bottom here. If there are existing radiographs, don't repeat them. If it's asymmetrical, do both sides. Otherwise, do one side. If you're worried about the C-spine, do a dedicated C-spine extension and flexion views. Look at the anatomical localization. Is it an acromelic? Is it a mesomelic? Is it a rhizomelic condition? Often when it's a micromelic and there's symmetry, it's not a dysplasia at all. And then are the epiphyses affected? Has the patient presented with joint problems? Are the metaphyses affected? Have they presented with bowing, which could be varus or valgus? Or is it, do you think, a diaphyseal condition? Then, if you're still not sure, look at the bones. Look at the surrounding soft tissues. I didn't talk about, for example, the phlebolyths in Maffucci syndrome, or the contractures in Bruch syndrome. Bruch syndrome is fractures, osteogenesis imperfecta plus pterygia, so the soft tissues would be contracted. Then look at the shape of the bones. We talked about how we could spend 2 days looking at the shape of bones. Bullet-shaped vertebrae in achondroplasia, clover-leaf skull in Pfeiffer's or thanatophoric, the shepherd's crook in fibrous dysplasia, the harlequin mask in osteopetrosis, on and on and on, so many examples. Look at the size of the bones, and actually from the very beginning, we've talked about size, haven't we? Micromelic, mesomelic, those are all talking about size. Remember that if the head, when you talk about microcephaly, you mean in relation to the rest of the body. So the skull is not microcephalic if the whole child is small. If the body is the right size, but the skull is small, then you have microcephaly. In terms of size, we said that expanded ventricles in achondroplasia is not the same as hydrocephalus, it's ventriculomegaly. And then we looked at structure, and we talked about increased density, reduced density. I showed you osteopetrosis with a uniform increased density. Then I showed you infantile, juvenile osteopetrosis with a rugged Jersey spine. But you could have osteopathia striata with striated metaphyses. You could have osteopoikilosis with the bone islands, And then we also looked at reduced bone density and talked about osteogenesis imperfecta. And I said, anytime you think about osteogenesis imperfecta, you must automatically think about hypophosphatasia because we can treat it. And then finally, we talked about the sum of the bones, pre-axial polydactyly, post-axial polydactyly. The bones may be fewer because they're fused. So things like that give you fusion of the radius and ulna, you should always think about those. We moved on to complications. And remembering that for the child and for the family, the complications are sometimes more important than making a diagnosis if you don't know what the diagnosis is. And we touched upon lots of characteristic features that we might see, the exostoses, for example, and remembering that a characteristic feature might be absence, the absent clavicles in cleidocranial, for example. And then we looked at how the same gene in the same, so conditions in the same group might be lethal or non-lethal, which is what the other D was for. And here's, I'm showing you Morchio again, and then just a radiograph of hypophosphatasia. Don't miss that diagnosis because we can keep that child alive through enzyme replacement therapy. So back to those, hopefully you now know what mesomelic means, rhizomelic, micromelic, and acromelic. I don't think we need to sort of go through those answers in a separate way. I've talked about it all the time through this talk. But here we know it. Mesomelic middle, rhizomelic proximal, micromelic all segments, and acromelic is the distal, the hands and the feet. Here we have those radiographs, and every single one was shown in the course of this talk. I used the exact same examples, and so maybe we can see now. So A is cleidocranial, characteristic feature is absent, the clavicles. B is achondroplasia, very subtle, very difficult, but that left proximal humerus metaphysis is sloping. The ribs are short. You're seeing far more of the scapulae outside than you should be seeing, and the anterior rib ends are not coming out, are not coming anteriorly very far. C is maybe harder to know. It's Jeune. It's a short rib, polydactyly syndrome with or without polydactyly. Those, maybe the pelvis would be easier to help you make a diagnosis, but it's a live child. They often are live and very short ribs. And again, notice how much of the body of the scapula you're seeing outside of the ribs. And D is hypophosphatasia. It's the example I showed you up against the osteogenesis imperfecta chest radiograph, and we talked about the proximal, the bands of radiolucency running down the metaphyses. And then looking at the pelvis, you must surely have now recognized that A is Morchio. I think I showed that more than once on several radiographs. B is what you want to come out of this talk with. If nothing else, come out with this talk recognizing the ice cream scoop appearance of the proximal femur in achondroplasia. C is obviously metaphyseal chondrodysplasia type Schmidt, Remember that rickets affects the knees and the wrists the most. Schmidt affects the hips the most, and hypophosphatemic rickets affects the medial sides of the distal femur and proximal tibia the most. And then this radiograph D is, if you have noticed, it was the same radiograph I showed you where I pointed out the iliac horns in nail patella syndrome. So if you want to do a bit of reading beyond this, this was a special issue that we did on skeletal dysplasias. I particularly like the genetics at the bottom here, this paper for pediatric radiologists. It talks about the genetics, giving us just enough that we need to know without going into too much detail. I see Dr. Khan has turned his video on. He's telling me to hurry up, but I will say that I was given an hour and we started 5 minutes late, so I'm actually
excuse me no, not at all. Please continue for as much as you want. So I'm
thank you. I have 3 minutes left. Thank you very much. I now need to work out how to stop sharing. I'm still, yeah. Okay. I don't know, do we take questions or do we thank you. I see the clapping. I'm grateful.
Yeah, absolutely fascinating. It was mind-blowing, and this is what everybody thinks because the chat is absolutely on fire. I cannot read the comments right now because there are too many, but I'll give you in writing what they have said in the chat.
Thank you. It would be nice to see that.
And audience does realize that you are a